Great. Thank you so much, both Dr. Ferrari and Dr. Salerno. I really appreciate the opportunity to be here. I have no financial disclosures. Ischemic heart disease remains the most common clinical scenario encountered by cardiologists. There is over $10 to $12 billion in wasted expenditure per year in the U.S. alone evaluating non-cardiac chest pain with cardiac testing. And despite primary prevention measures, still over 50% of cardiac mortality is encountered outside of acute hospitalizations. Perhaps one of the most important trials to evaluate the treatment of ischemic heart disease to date was the COURAGE trial, which randomized over 2,200 patients with stable coronary artery disease to an initial treatment strategy of invasive revascularization compared with medical therapy. And we can see here the Kaplan-Meier survival curves for the primary endpoint of all-cause mortality and myocardial infarction, and surprisingly, there was no difference with the treatment strategy of invasive revascularization. Perhaps in retrospect, we should not have been as surprised with the findings of COURAGE, as prior to the COURAGE trial, there had been 8 studies that had actually failed to demonstrate either a mortality benefit or a reduction in myocardial infarction for invasive revascularization. More recently, the FAME trials have increased clinical equipoise regarding the clinical benefits of invasive revascularization. The larger and more recent FAME2 trial randomized over 1,200 patients who had evidence of anatomic stenosis on cardiac catheterization, as well as further hemodynamic invasement by fractional flow reserve using an intracoronary pressure wire. And those patients that had both evidence of stenosis and an FFR of less than 0.8 were randomized in very similar fashion to COURAGE. Their primary composite endpoint was death, myocardial infarction, and urgent revascularization. And interestingly, the FAME2 trial was actually stopped early after 7 months because of a significant reduction in the primary endpoint with invasive revascularization. However, this was all powered by a reduction in urgent revascularization. And I'd just like to remind you, for FAME2, there did not need to be either objective evidence by cardiac biomarkers or clinical imaging to substantiate myocardial ischemia. However, when we looked at the harder clinical endpoints of myocardial infarction and all-cause mortality, once again we see no significant difference for invasive revascularization and optimal medical therapy. So this may lend the question, is the evaluation of myocardial ischemia important? Well, this is data from Dr. Hakhomowicz and colleagues, retrospective analysis of over 10,000 patients with nuclear perfusion imaging. And Dr. Hakhomowicz identified that those patients who had more substantial degrees of ischemic myocardium derived a mortality benefit from invasive revascularization as opposed to medical therapy. And those patients with lesser degrees of ischemia, there was no difference. This is reflected in the most recent iteration of the American Heart Association ACC Guidelines, which actually suggests that decisions for early invasive revascularization should be based on an assessment of patient risk on annual rates of cardiac mortality. Unfortunately, some of our standard techniques may lack sensitivity for risk stratification. Although earlier studies suggested that patients who had a normal nuclear perfusion scan had a very good prognosis with less than 1% annual risk of cardiac death, more recent studies have highlighted subgroups of patients that may be at much higher risk even in the setting of a normal nuclear perfusion scan. And that includes data from Dr. Rosansky and colleagues who looked at patients who underwent a pharmacological nuclear perfusion scan as opposed to a exercise, patients with a high calcium score, diabetics, and patients with morbid obesity. This also has significant real-world implications. This is data from Dr. Patel and colleagues who looked at almost 400,000 patients who underwent elective cardiac catheterization in the United States. And they identified that despite the fact that 84% of these patients had some form of non-invasive testing, the rates of obstructive coronary artery disease were less than 38%. Furthermore, there are also now emerging concerns regarding iatrogenic exposure to ionizing radiation from medical testing. This is data from large integrated healthcare systems, almost 2 million patient members, and over a 15-year period we can see an almost linear increase in the median dose of radiation that was delivered to both the top 10% and top 1% of exposed enrollees. And for the top 1%, the median dose was over 100 millisieverts, which is a very high dose of radiation. So in summary, invasive procedures such as percutaneous coronary intervention, which is our mainstay of therapy, carry risk and morbidity for ischemic heart disease management. Risk discrimination is of paramount importance to develop favorable risk-benefit profiles for invasive intervention. And unfortunately, our standard techniques for risk stratification may lack sensitivity in certain subgroups and often involve exposure to ionizing radiation. And this brings us to the wonderful world of stress CMR, which may be able to address and attenuate some of these issues. As was described earlier, stress CMR may be performed by different techniques. Ergonomic exercise may be performed with a non-ferromagnetic treadmill or a supine bicycle. Patients can have administration of a intravenous synthetic catecholamine, dobutamine, which increases myocardial oxygen demand and myocardial contractility. And most commonly, patients can receive an intravenous vasodilator for perfusion stress MR, which creates differential hyperemia in patients with ischemic heart disease. As was described earlier, stress CMR has numerous advantages. It has both high temporal and spatial resolution. It is not limited by adverse body habitus and has relative operator independence. We can evaluate coronary origins and proximal coronary course, which may be particularly important in younger patients without the use of radiation. It can provide in one test a comprehensive assessment of myocardial ischemia, ventricular function, and myocardial viability. And finally, there is no radiation and an excellent safety profile. There are, however, some disadvantages to stress CMR. Patients who have a non-MRI compatible metallic device cannot undergo stress CMR. Patients with significant renal dysfunction are relatively contraindicated from contrast administration, and patients with severe claustrophobia may not be able to tolerate a CMR. Here we see a standard stress perfusion CMR protocol. This was the protocol we employed at Brigham and Women's Hospital as well as at the University of Calgary. Patients are placed in the CMR scanner and we obtain localizers for cardiac imaging planes. Stress perfusion imaging is then performed with a concomitant bolus of gadolinium and an intravenous vasodilator. Can use an adenosine or dipyrimidinol infusion or a bolus of regadenoson. Following stress perfusion imaging, patients go on to have accurate assessment of structure and function, as Dr. Kramer nicely illustrated. Patients receive a second bolus of gadolinium for rest perfusion imaging, and finally we have delayed enhancement. And in particular, the significant advantage of CMR for evaluation of ischemia is that we can identify stress perfusion defects in myocardial segments that have no matching late enhancement, suggesting that these segments also have viability. Once again, as Dr. Kramer nicely illustrated, we typically perform 3 short axis slices of the base, mid, and apical ventricle, which correlates very nicely with the AHA 16-segment model. And this also provides corresponding coronary artery territories. Here we see an example of a patient with a stress perfusion defect. We can see a very dense subendocardial black band in the anterior and septal segments. This patient went on to have cardiac catheterization and had a severe proximal left anterior descending artery stenosis. Furthermore, as I had alluded to earlier, on the left here we see a patient who has stress perfusion defects both in the inferior and lateral segments. When we compare to the corresponding short-axis late gadolinium enhancement image, we see although there's evidence of a prior inferior myocardial infarction with subendocardial late enhancement, there is no late enhancement of the lateral segments. And indeed, when this patient went on to have cardiac catheterization, this patient had developed a new significant stenosis in the left circumflex territory of the large obtuse marginal artery. So stress perfusion CMR has numerous advantages, but is it useful? Can it be used in the emergency department, particularly for the evaluation of patients with acute chest pain? Well, on the left here we have data from Dr. Plein and colleagues who evaluated 68 patients who presented to the emergency department with symptoms of unstable angina. And utilizing stress CMR, they found really quite remarkable diagnostic accuracy, a sensitivity of 96% and a specificity of 83% for a comprehensive CMR examination. Furthermore, as I alluded to earlier, in addition to diagnostic accuracy, prognostic performance is exceedingly important to discriminate risk amongst our patients. And Dr. Inkenassorn and colleagues evaluated 135 patients presenting with acute chest pain to the emergency department, and they found that on the basis of either a negative or positive stress CMR result, there was significant separation of the Kaplan-Meier survival curves for freedom from adverse cardiac events. Interestingly, Dr. Vogel-Clausen and colleagues also evaluated a cohort of 31 patients who presented to the emergency department with chest pain and normal enzymes. All of these patients underwent both nuclear perfusion imaging and stress CMR. And surprisingly, they found that in a substantial proportion of patients who had a normal perfusion, nuclear perfusion scan, these patients had an abnormal stress CMR. And here we see two examples, patient A on the left and patient B on the right, both of which have a normal nuclear perfusion scan. But when we look at the stress CMR images, we see that patient A on the left has multiple dense stress perfusion defects suggesting multivessel coronary disease, while patient B on the right has a normal stress perfusion examination. In addition to evaluating for ischemic heart disease, a stress CMR also allows for the evaluation of numerous other causes of chest pain other than ischemic heart disease, including pericardial disease, myocarditis, and stress-induced apical cardiomyopathy. So it can be quite useful. Now, we had heard that potentially there are some concerns regarding cost. CMR is an expensive modality, and cost effectiveness is a very substantial area of modern research in CMR. And we see here Dr. Miller and colleagues evaluated 110 patients presenting to the emergency department with chest pain, and they randomized these patients to an initial treatment strategy of stress CMR versus standard care in the emergency department. And very interestingly, they found that almost 80% of patients in the stress CMR arm were discharged directly from the emergency department, while almost 70% of the patients in the standard care arm required admission for further inpatient stress testing. None of these patients had any events at 30-day follow-up, but the total cost of care was reduced in the stress CMR per patient. And very interestingly, the median cost saving of $588 is almost the exact same value that Dr. Hoffman and colleagues found in the RAMICAT-2 trial for the use of stress CT in the emergency department, cardiac CT. So what about patients with stable coronary artery disease? Well, there have been a number of single-center studies evaluating the diagnostic accuracy with quantitative coronary angiography as the gold standard. And Dr. Nagel and colleagues recently published a meta-analysis, and once again we find quite impressive diagnostic accuracy. Similarly, for stress perfusion CMR, a meta-analysis published in the same year, 26 single-center studies, over 2,000 patients, and we see an overall sensitivity of almost 90%, specificity of 80%. Perhaps one of the most important studies in the MRI field to date, the CE-MARC trial performed by Dr. Greenwood and colleagues. This was a prospective diagnostic performance study where patients received both stress CMR and nuclear perfusion imaging, once again with quantitative coronary angiography as the gold standard. And once again, we see quite amazing diagnostic performance, sensitivity of 87%, specificity of 83%, whereas nuclear perfusion imaging had a more limited sensitivity. Dr. Nagel and colleagues have also performed a study in over 200 patients comparing dobutamine stress CMR to dobutamine stress echo, and once again found both a higher sensitivity and specificity. And this was largely powered due to resting wall motion abnormalities and reduced ejection fraction, which can reduce the sensitivity and specificity of stress echocardiography, but not stress CMR. Dr. Watkins and colleagues have also compared the diagnostic performance of stress CMR to FFR hemodynamic assessment, and once again we see quite outstanding sensitivity and specificity. But as I alluded to earlier, it's not enough to have very good diagnostic accuracy in comparison to quantitative coronary angiography. To manage our patients, we really need to have quite excellent prognostic performance to discriminate risk. And numerous groups have published on the strong prognostic performance of stress CMR. We evaluated over 800 patients who had been consecutively referred for stress CMR at Brigham and Women's over a 10-year period. We found an excellent safety profile. No patients had any adverse events during stress CMR. 97% of the studies were diagnostic, and we also identified a high-risk cohort that had established coronary artery disease at the time of their imaging. And here we see the annual event rates for cardiac death, which the most recent iteration of the guidelines suggests utilizing for making decisions regarding invasive revascularization, stratified in blue by those patients with no evidence of inducible ischemia versus those patients in red with evidence of ischemia. And we see that the patients with no ischemia had exceedingly low annual cardiac death. And even in our highest risk subgroup of patients with established coronary disease, we see very low rates of annual cardiac death. We then went on to perform a net reclassification index to see if this had real-world potential to help us manage our patients. We looked at the patients who had a moderate pretest risk of cardiac death and myocardial infarction. These are patients that are difficult to manage because they're neither low risk nor high risk, so it's often difficult to make decisions in these patients. Based on the results of the CMR, we were able to reclassify more than 90% of these patients. 65.7% were reclassified as low risk in green, and almost 26% reclassified as high risk. And when we look at the post-test event rates for cardiac death and myocardial infarction, we see those patients reclassified to low risk had exceedingly low rates of cardiac death and MI, 0.3% per year, versus those patients reclassified to high risk were indeed quite high risk. In addition to general testing, stress CMR also allows us to image patient cohorts that have been traditionally very challenging to image with standard techniques, and that includes patients with obesity. Patients with obesity oftentimes have attenuation artifact from the breast and diaphragm with nuclear perfusion imaging. They can have very poor acoustic windows with stress echocardiography and require higher radiation doses. And as I'd alluded to earlier, nuclear perfusion imaging may also have limited sensitivity in these patients. And we looked at a cohort of over 250 patients who had a body mass index of greater than 30. Once again, we see quite impressive risk discrimination with either a negative in blue or a positive in red stress CMR. Likewise, women can also be very challenging to manage. Women often present with atypical symptoms. In fact, the most common symptom that women present with ischemic heart disease is fatigue, not chest pain. Women can have a twofold higher cardiac mortality post-acute coronary syndrome. They often have less obstructive coronary artery disease at the time of invasive catheterization. Nuclear perfusion imaging, once again, may have limited sensitivity and specificity due to breast artifact, and there are now quite emerging concerns regarding increased risk of breast cancer with ionizing radiation. And again, data from Brigham and Women's, over 400 patients. Once again, negative versus positive stress CMR. We see quite a difference in rates of cardiac death and myocardial infarction. And this risk discrimination was equivalent between men, shown in green, and women appropriately shown in pink. That's just a joke. Finally, diabetics can also be notoriously difficult to risk stratify, secondary to the fact that these patients can have peripheral vascular disease, peripheral neuropathy. They may not be able to exercise. They also tend to have a higher prevalence of multivessel coronary disease. And once again, in diabetics, we see quite excellent risk discrimination by stress perfusion CMR. Well, we come back to this question of cost effectiveness. Is stress CMR cost effective in risk stratifying these patients? We looked at our CMR database and matched these to almost 40,000 patients who had undergone nuclear perfusion imaging at a hospital across the road, Mass General Hospital. And again, we find that for those patients who had a negative CMR, they had a significantly lower event rate than those patients with a negative perfusion scan, while those patients with a positive CMR had a significantly higher incidence of adverse events than those patients with a positive SPECT. And when we did the economic analysis, once again, we find stress CMR is associated with an 18% lower cost per quality adjusted life year. And Dr. Greenwood and colleagues have also published the prospective economic analysis from CE-MARC and also demonstrated cost feasibility for stress CMR over nuclear perfusion imaging. Just a few slides about some improvements in diagnostic accuracy. Although Dr. Michael Josh Harold couldn't be here in person, he's here in spirit. He has provided these images for us. And we see a comparison of 1.5 T on the left and 3 Tesla stress perfusion images on the right. And has been described earlier with higher magnetic field strength, we get improved signal-to-noise ratio. And you can see here it's much, the stress perfusion defects in the septum are certainly much more readily evaluable. And this was actually assessed by Dr. Chang and colleagues, once again with quantitative coronary angiography as the gold standard. They evaluated over 60 patients who had both stress perfusion imaging at 3T and 1.5T, found a higher diagnostic accuracy overall, but in particular for single vessel disease, a much higher area under the receiver operator characteristic curves. Finally, as we'll hear in subsequent lectures, quantitative perfusion by both semi-quantitative and fully quantitative methods have also shown quite impressive diagnostic accuracy. This is data from Dr. Patel and colleagues who found higher sensitivity for semi-quantitative perfusion analysis in comparison to qualitative interpretation of stress perfusion CMR alone in 30 patients. Thank you so much for your time and attention. I really appreciate it.